I'm going to call the meeting to order, and I'd like to start with the territorial acknowledgement. Cambridge Memorial Hospital is located on the Haldeman Tract. After the American Revolution, the tract was granted by the British to the Six Nations of the Grand River and the Mississaugas of the Credit First Nations as compensation for their role in the war and for the loss of their traditional lands in upstate New York. Of the 950,000 acres granted to the Haudenosaunee, less than 5% remain Six Nations land. Only 6,100 acres remain Mississaugas of the credit land. We thank the Anishinaabe, Haudenosaunee, and Chinantan for hosting us on their land. Welcome, everyone. I'd like to extend a special welcome to Kellen. It's so great to have you here. I have already had the benefit of seeing you do this once, but I wanted to make sure that I know what all of the committee members also did. But anyway, it was so inspirational and interesting. And anyway, I'm thrilled to have you here.
I appreciate being here.
Thank you.
Thanks.
And I can confirm that we do have quorum. Are there any declarations of conflict of interest for the open portion of the meeting? Okay, seeing none. Would any board members like any items removed from the consent agenda? It is quite a lengthy consent agenda.
If I could get a brief clarification of mention March MAC report, which is 1.5.6.5. Page 33, item 5 talks about strategic plan for CMH and organization flow, and it makes reference to something called market share leaking.
Okay.
I wonder if we might just have a brief discussion of that.
Okay. Winnie, is that a quick 1-2 sentence answer, or should we pull that out and have a more lengthy discussion on that?
I think it's a quick one. It was actually reference to some updates that Patrick was talking about master planning, and that we were doing some early environmental scanning of what current volumes are for different programs, and that we're seeing some loss of volumes in certain programs.
To other
area hospitals, yes.
Is that because it's truly because of capacity? I mean, we are turning down business?
No, not necessarily. And that's the idea is to understand and to do a deep dive as to what it is. So sometimes it's needs, sometimes it's access, sometimes it's a type of programs aligning with the needs of the community as we age. So
It's the capacity is the answer to the issue.
not necessarily. No, not necessarily. And I think it's just a first starting point to understand what the environment is.
I think the deep dive is to figure out why we're losing, like why the market leak, what are the reasons for the market leakage? And then that will help inform the master planning.
Okay, thank you.
Does that,
That's right.
okay, perfect. Would anyone, any other questions or anything that people would like removed from the consent agenda? All right, before I ask for a motion to approve the consent agenda, I just want to recognize from both the board and staff perspective, if you looked at the work plan, May and June are very heavy months, and I am thanking you all in advance because you are going to be asked to do a lot over the next 2 months. So thank you. And I also wanted to recognize from the MAC reports, the work by the Med Department on the increased specialization, GMRAT, the working groups on recruitment, innovation, and then also recognize the 3rd Trillium Gift of Life Award. So congratulations. Thank you. With that, if I could ask please for a motion to approve the consent agenda. Jane, thank you. Seconder. Monica, thank you. Any further discussion? Anyone opposed? Carried. All right, so then moving on to confirmation of agenda. May I please have a motion to confirm the agenda as presented? Bill, thank you. Seconder, Paulo, thank you. Any questions, comments? Anyone opposed? Carried. All right, I am passing it over to Kellen, and the package starts on page 94, but I will let Kellen let us know where he wants to go. So
Perfect. Yes, 94 is great. Hi, everyone. I think I know most in the room, but just to cover my bases, my name's Kellen. I'm the patient safety and quality lead for the organization. and I'm here today to speak to Just Culture. I really appreciate the invite. Now, off the top, you'll notice I have notes with me, not just because I want to be too scripted, but because Just Culture has taught me that relying on my memory alone is a risk factor. So I do appreciate the opportunity to speak to Just Culture, not just as a concept or policy, but as something that people actually experience across the organization when things don't go as planned. Before I begin, I want to thank Dr. Winnie Lee, who has partnered with me on this work and is a strong champion for Just Culture. Now, for context, and I know Lynn alluded to this, but a version of this presentation has been shared widely across the hospital. It's to medical leadership. It's been a few times to our medical advisory committee, to operational leaders, human resources, health, safety, wellness, professional practice, and it's going to go to union leadership and joint health and safety. So broad engagement, and it's intentional to do so because if we want to truly live our values and embed a just culture, and recognizing culture change is really, really hard. We need a shared understanding across roles, disciplines, and at all levels of the organization. And now from a board perspective, just culture matters because it influences what people feel safe to say, what issues actually surface, and whether responses across the organization are experienced as fair and consistent. So when something goes wrong, how we respond often matters as much as what happened. Those responses, they influence trust, learning, and ultimately patient safety and enterprise risk. So my slides were pre-circulated, so they're pages 94 to 110 in your package. And they are built around this simple framework: see it, know it, apply it. And I want to start with see it by looking at how easily our understanding can differ when we're all looking at the same situation, and why that matters when we're trying to be fair and consistent. So with that, one of the slides alluded to an interactive activity, and so I'm going to pivot. We've tested, so this should go smoothly. So this is a short video. The instructions are in the video. There is volume, but you don't need volume. I just ask pay attention, and then the prompts will ask things of you.
The monkey business illusion. Count how many times the players wearing white pass the ball. The correct answer is 16 passes. Did you spot the gorilla? For people who haven't seen or heard about a video like this before, about half missed the gorilla. If you knew about the gorilla, you probably saw it. But did you notice the curtain changing color or the player on the black team leaving the game? Let's rewind and watch it again. Here comes the gorilla, and there goes a player, and the curtain is changing from red to gold. When you're looking for a gorilla, you often miss other unexpected events. And that's the monkey business illusion. Learn more.
Had most seen that before? Is that new to some? Okay, great. So the first time I saw the video, I missed the gorilla, like the video said, about half miss it. And initial reaction, if you did happen to miss it, and no one needs to disclose whether they did or didn't, you might think, okay, I can't believe I missed it, or the curtain changing color. But what's really happening is we were doing exactly as we were asked to do. the video asked us to count how many times the ball was passed. And so I have one more quick exercise that shows how strongly tasks guide our attention. This one people might be familiar with, especially if you have children. It's a Where's Waldo. It's small up on the screen, so don't stress if it's challenging. I'm going to put it up and just maybe give 20, 30 seconds. The clarity might not be great either. You're looking for Waldo. It's the red and white stripes, glasses, and the red and white toque. And maybe if anyone has great eyes and is able to see Waldo, if you just raise your hand if you did find him. And that's okay. Actually, my exercise works fine either way. So I'm going to reveal to you where Waldo is. He's up there.
I did, but I wasn't sure if this is.
And when it's easier to see, you start to see some hands go up. People are seeing him at different times. But what I'm curious about, and if I can get a few people maybe to say, and if you've done Waldos in the past, it's the same thing. But what is your typical strategy, or what was your strategy in this case to try and find Waldo?
I always check the corners first.
Corners. So all corners, and then after that, where do you go?
Then I start scanning.
Scanning, left to right,
This time I actually started right to left.
right to left. Yes.
I divided it in strips, but unfortunately started at the bottom.
Like, I was actually looking for the stripes, because I knew he had the striped shirt, so I started with the. stripes.
Okay, so you're looking at are you going everywhere on
Yeah,
there?
I'm ready to see where the stripes are. Yeah.
Perfect.
I thought it was a trick, so I thought it was the postcard. I just started looking. I know
So in this case, so we all have the same image and the same goal. We were all looking for Waldo, but there are different strategies, and ultimately those would have led to different outcomes if the outcome was like, how long did it take to find Waldo? And that's what happens when people interpret and respond to real world situations in different ways. What both of these are intended to highlight is that what we see and what we notice, and what we conclude are shaped by our focus and our perspective. And in healthcare, that means the same incident can be interpreted very differently depending on the role, the experience, your expectations, and even your biases, which leads to a lot of variability in the response. And that's the problem that Just Culture is trying to solve. Just going to move forward to this slide. So when we talk about Just Culture, we're really talking about how we respond when something goes wrong. Just Culture starts with a simple assumption. Most people come to work wanting to do a good job. People get into healthcare, they want to help people. And healthcare it's complex. There can be high stakes. It can be fast paced. So, and even skilled, experienced, and well-intended people can make a mistake. And so Just Culture acknowledges that reality while still maintaining that there is professional accountability. So the intention is to balance system factors with individual responsibility. One of the most important shifts Just Culture introduces is a shift in questions. Instead of asking who is at fault, so on this graph, the punitive side, who is at fault? Or saying no one is at fault, no one has accountability, which is the blame free. We want to live in the middle. And we want to ask what happened, what made sense to the person at the time, what conditions shaped the outcome. Those questions don't remove accountability, they make it more thoughtful and consistent. And from a governance perspective, that consistency matters because it builds trust for staff, clarity for leaders. And the intent is that it would provide more assurance for the board that responses are aligned with our values and are focused on learning and safety. So I'm going to move to our decision tree. So to support that consistency, we've worked to develop a shared decision-making tool. This is our very own version of a Just Culture decision tree. Now it's 104, I believe it's 104 in your package. And it's also, I've provided a version for those in person. And I know it's the open session, so if you can also access, it's an appendix in our Just Culture policy, which you can access on SharePoint. So this is the apply it section. And as we move into applying it, I want to be clear about what the tool is and what it isn't. It's not diagnostic and it doesn't give us an automatic answer. What it does provide is a shared language and a set of consistent questions to filter our understanding and guide fair and just responses. So as we work through this, I'm going to be asking you to help me navigate the decision tree. So I want you all to think of yourselves as the decision makers here, and I'm just facilitating and navigating the slides. And so to ease us into this, and it was in the package, but to ease us in, we're going to start with a scenario where the biggest risk is disappointing dessert expectations. At risk of sounding like a Sherlock Holmes or mystery novel, this is Julia Child in the case of the salty cookies. So this is the scenario. Julia Child pours salt instead of sugar into a cookie recipe. Additional context, Julia is an experienced baker and cook. And normally double checks ingredients. There was a momentary distraction. She glanced away to check at a timer. The cookies are ruined, but no one is hurt. How would we manage this? How do we best respond? So we're going to apply our Just Culture decision tree. And I have it where we're going to zoom in. So we're starting at the start here. Was the action deliberate? Did Julia Child intentionally put salt in the cookies? No. Okay, so we move along.
It would need to be vocal.
Yes, please. I'll jump through the cases and I'm gonna please join in. So that's called the deliberation test. We move over to the health test. Does there appear to be evidence of ill health, substance use, or other impairment with Julia Child? No. In the case that I provided, we say no. So we move over. Did the individual depart from existing policies, procedures, bylaws, recipes, or professional college standards? Yes.
Yeah.
So we move down. Was the policy, procedure, bylaw, recipe, or standard clear, usable, and routinely followed? Yes, we assume yes, and maybe it could be at a point where you want to investigate more and then make sure that it is clear.
It's a brand new recipe.
That's right. Maybe it was printed correctly, it cut off, who knows? And so we move down. This is called the culpability test. Did the individual knowingly take an unjustifiable risk by glancing over at the timer? Or is there an indication that's been repeated performance concerns with Julia Child? Per the case, not repeated. So we move no over to the top again. Would appear within the same work group or someone with a similar level of cooking, baking experience in a similar situation perform in a similar manner? No, and it can be yes too.
Yeah, I would think it'd be.
And honestly, we can go about if you put someone in the same situation, would they perform? Maybe sometimes, maybe not all the time. So, but it doesn't matter, to be honest, which we go. We can go either route. So if I'm the one applying the tool and I think, no, yes, I think if a similar baker was in the case, they could make that mistake regularly or could make the mistake. We move down, system failure. It says, the individual was working appropriately. The issue stemmed from system factors. Identify and address the system issue to prevent reoccurrence. Maybe the timer needs to be in a place where she doesn't need to glance away when doing the ingredients. But someone using this tool could go down could say no. No, I don't think if I replace Julia Child with someone else, I don't think anyone would people wouldn't make that same mistake. So then we go down to, were there deficiencies in training or experience with Julia Child as it relates to baking? No. And did they choose the behavior? And again, it's that deliberation. Did she intentionally do it? So no. And then we go down to human error. And if we read it, it says the individual made an error while working appropriately. Avoid singling out the individual, as most human errors stem from system issues. So there's a great connection between human errors and system issues, and sometimes it's gray, sometimes it crosses, but it's a similar side of the tool. Recommend support or coaching and identify system level actions to improve safety. So someone can reasonably land in both areas, but it's a similar guidance. So that's our test at trial of the tool. I have one more case that I adapt a bit. The intention was to make it a case that maybe you might see or hear of. So but it is a fake scenario. So a family member posts on social media and takes our hospital. They are expressing concerns about the care of their immunocompromised mother while she was admitted to the hospital. The post alleges that a named staff member repeatedly entered and exited the patient's room without performing hand hygiene, suggesting this posed a risk to that patient. And the post, it gains traction online, and board members inquired with management about the tagged content. Additional context, the patient did not experience documented harm related to infection, and the staff member has no prior history of hand hygiene concerns or related performance issues. So we're going to apply the tool. I don't have the zoom in function, but I can move back if that's helpful. So was the action deliberate? Did the individual go in and out of the rooms not performing hand hygiene, if we accept that as true, intentionally?
Think so.
Don't think so. Monica says I maybe think so. Yeah. And
There's no evidence of it being deliberate.
And this is really good because the case doesn't say exactly. We don't know if I don't need to wash my hands. I've done it a whole bunch of times. I'm going in quickly, or if it was a true lapse miss. I forgot. But if you can't answer the question confidently, it likely means that you need to investigate further. So it might be a prompt for a leader who's actioning on this to be like, I need to know more. What more can I learn to help inform whether I know this was deliberate or not? Maybe I need to interview the staff member. Other ways to kind of investigate to try to get as much clarity as you can. But for the purposes of this, I'm going to tell you that this individual said that, yeah, I just did it quickly. I just washed my hands. I went in really quick and I didn't do hand hygiene. So for this purposes, I'll tell you, yes, they did it deliberately. So that brings you down, just so you get a full scan of the full tool. Was the action intended to cause harm? By skipping that step, by not doing the hand hygiene that time, was the intent malicious? Was I trying to hurt the patient by doing that? Likely not. There's nothing in the case. I would think that's not the action of most people, but we want to be able to confidently say no. Up to the health test, nothing in the case says that there's a concern regarding health. Did the individual depart from procedures? Yes. The policy was clear, routinely followed. Everyone else is washing their hands. Yes. Was it an unjustifiable risk or repeated performance concerns? So the case says that there weren't performance concerns. Was it an unjustifiable risk to go into the room without washing your hands? Maybe. Yeah. So that makes you land in reckless behavior. And it says the individual knowingly made an unsafe choice. Assess the need for remedial or disciplinary action based on policy, reinforce expectations for safe practice, and ensure accountability is applied fairly and consistently. So if everyone else is on the unit doing it and we don't actually, we should be consistent across all people who perform in a similar way. Perfect. And now I'm adapting the case. So the context is the same, and I'm just tweaking it a bit to see if it moves us in any way on the tool. So the bolded part is what I've changed. That says colleagues report it to be a repeated behavior of the staff member. In the same spot. No, right. So it hinged on that unjustifiable risk and repeated performance concerns, and it lands in a similar spot. And I'm adapting it again. The staff member reported working extended shifts with inadequate rest and experiencing significant fatigue during that shift. They said, I wasn't at my best that day. I recognize I didn't follow hand hygiene as I should have, and I'm sorry. Now, how does that shift where you might land on the tool?
Fair judgment.
Fair judgment, maybe. Yeah. Yep. Does there appear to be evidence of ill health, substance use, or other impairment? And maybe there's not enough information and maybe it's a case for health, safety, wellness. Maybe there's more investigation required. And it could be too, it doesn't have to only be one bucket. It might be there's an aspect. Yeah.
That's what I was going to ask.
Yeah.
Because so they chose to work extended shifts. However, our system allowed them to work extended shifts. So to me, that would be impaired judgment and system failure at the same time.
Yeah.
So.
Yeah. And with a lot of these problems, the complexity, you can break out different pieces of it, and it might land in multiple buckets, and you might be managing it in different ways, different to the different details of the case. But hopefully, if there's disagreement, if a few leaders are managing the case and they don't agree with where we land, whether it's shared or whether it's in one bucket, they're having the conversation on the right question. They're not disagreeing because, maybe you have a favoritism towards this staff member, or more, hopefully it's about the individual question and where we're landing. I said yes, you said no. Let's understand why we said yes or no to that specific question.
Any questions so far?
That was my question.
Yeah.
Okay.
Thank you.
Any other questions before Kelly? I just want to make sure that we're all not sitting here wondering something wrong with me. Okay, perfect.
Okay. So this is one of my final slides. Hopefully this is helpful and maybe a part of discussion. If there's specific thoughts we can talk about now, or I can save it for the end. But this was considerations for management versus board or board committee role. So under management, I have communicate with the patient, family, and provide follow-up in this case. Support and follow up with the involved staff member. Again, they were named publicly. There might be some shaming. There's something there. Conduct an investigation using this just culture decision tree, and implement and document the appropriate individual and system actions. For the board and board committee, it might be seeking assurance that just culture was appropriately applied, asking high-level questions about system factors like hand hygiene rates for that area or PPE compliance, considerations around culture and risk, thinking about the oversight role, and then also if there were individual performance concerns, that they were managed through established processes. If there's any burning thoughts here, I can pause. If not, I'll keep going. Yes.
So I'm just maybe a bit of a question, but just curious on how often other leaders would be brought into the thought process in the sense of, I'm making a decision, I'm thinking I'm landing on, let's say, impaired judgment, but now I have questions. So what's the ecosystem for that shared collaboration on that final decision?
Right. Yeah, it's a great question. The intent is that this is a tool that's not specific to an individual area. I had a comment from MAC, Medical Advisory Committee, that I could use it with my children. This is not healthcare. This is not healthcare specific. And you could be using the tool and you could land, but at least in these walls, it could be that likely the details of the case that you're managing for might necessitate you working with others. So it could be that I need to bring it to, human resources. It could be a manager identifies and is working with chief of staff office. The hope is that at least we have a shared language and a shared tool to communicate across different areas. Again, if it was an impaired health, it could be health, safety, wellness. So I think it's likely case specific, but the intent of the tool is that at least we can use this as a basis of managing. That is a communication tool.
That leads me to a question that you may prefer to answer at the end, but
Sure.
This is an impressive approach. So my question is, to what extent have we deployed this in the organization? And
Yeah.
if we have yet to deploy it, what's the process for doing so?
Yeah, it's a great question. I arrived to CMH in 2023, and I remember during the accreditation survey, we were asked about just culture, and I had said that, we're on a journey, and we are, and because culture change is so challenging, it has been a lot of work to get to this point. We have a just culture policy that we approved in 2023. This was our next step. Was how do we not just stand behind a policy and say we agree with it in theory? How do we better support our leaders, support staff about how do we action on the concept of just culture? And that's the intent behind the tool. But not only is culture change challenging, I think our next step is how do we know how well we're doing with applying it? We do have the global workforce survey, which we're mandated to do as a part of accreditation. And there are questions in there that ask about your culture, like ask staff about the culture, which might be a good barometer of how we're doing. What we've done with this tool is not only socialize it across the whole hospital, we've also made it public within the policy because we would want staff members to also understand how we would be applying it. So that if I'm a staff member and I feel like I'm not being treated fairly, maybe I'm being targeted, I don't think I'm being treated fairly, a leader could use this as a communication tool with staff too. This is my understanding of the case. This is how we landed. It's not about me or you. It's not about my individual, this is what we have endorsed as an organization. This is how we landed where we did. And if there is disagreement, just like with different leaders, hopefully it's around particular questions. And it could be details that need to be investigated further or, so that's where we're at now.
If I were to bump into somebody in the hall and say just culture, I wouldn't expect them to recite this,
No, not likely that.
but would they at least be socialized to the notion?
I hope so. I hope so. So I know Patrick speaks to it in our hospital-wide orientation, and so do I. We've done a lot of, I've been ad nauseam, I'm sure I've been talking about just culture for the last year. And so it is hard to reach, as a part of our safety cast, our patient safety newsletter, we did a whole issue just on just culture. We are doing our best to try and make sure that people are not only aware of the concept, but our efforts to try and reach that. Because ultimately what we want is staff feel safe to say something when something goes wrong. We know that's safer for patients. We know that, that we are in a better environment if there's trust that we will respond fairly and that if there's an incentive. If I'm an individual nurse and I just made a med error, my incentive isn't to hide it because I'm worried about how someone might respond. I know that if I raise it, if I submit an RL, an incident report, that it will be managed fairly and consistently.
It certainly supports our values.
Yeah, great.
Sorry, how many, have you done 10 to 15 presentations or?
It's a good question. I would say we're in the area of 15.
Okay.
We also presented at, we went to a patient safety conference this year at Mackenzie Health and presented on our work in this area. I think it's an ongoing process. I don't think we're going to put it aside. I might not be doing the road show as consistently, but we know that just culture is embedded in really in my portfolio and so much of what we do. So we want to continue to bring it back to that concept.
But people, sorry, I'll stop asking questions. Monica?
I don't really have a question. I
Sure.
just a comment. A few of us around the table were in a quality committee when this concept first rolled out.
Okay.
Like, I think 2023. And it's really nice to see this coming back even in a laminated form. So kudos for taking a theory, a concept, and then bringing it into the organization. So thank you.
Yes, thanks, Monica.
If I can just interject and say, sorry, back to Paulo's point. So there's actually been situations where, we've had leaders working with professional practice, working with HR, and coming to the table to say, when I first looked at the situation or heard about the situation, I jumped to this conclusion.
Mm-hmm.
Right. So when you go back to kind of seeing the gorilla or whatever, right? And some of that is preconceived, like your biases and all of those other things, right? But when you actually start working through here, you land sometimes in a different spot, and it's that consistent language. And I know we've had leaders that have reached back out to Kellen to say, impressive to be able to talk the same language.
It's in the chat then, so if you're okay, I'll just read it.
I was going to say, I didn't see your hand up here.
Sarah's asking, is there an appeal type process in the case of disagreement with initial results?
Good question. So the just culture is really a framing. Hopefully it's guiding discussion. We haven't made any changes to the actual processes of managing. And so in terms of appeal, it wouldn't be my area to speak to, but I will say, hopefully this is a language that we use, but it already, in working with human resources, professional practice and chief of staff office, it really hasn't changed the specifics on the management piece. It hopefully is just clarifying our decision-making that then informs, entering in existing processes.
I was going to ask, has there been any kind of negative feedback, people don't agree with it or they don't feel it's the right approach or any other?
I think our hill isn't a negative response when they understand it. It's honestly what is just culture as a term without context is hard to understand. And so we're trying to be creative with how we help bridge the gap. When I say patient safety, when I'm doing my patient safety is intuitive, it's keeping patients safe. Just culture isn't as intuitive of a term. So I think that's more so our hill.
Kellen, thank you for this. I think I understood what just culture was, but this really brought it home for me. So thank you. I'm a very visual learner, so I love the decision tree and well done. Thank you very much.
So I guess there's no reporting back. There's no way that you can say, oh, this has been applied
Right.
15 times in the last year. So we have no feedback on how it's,
No.
okay.
So we've added it to the clinical
I was gonna
incident.
say, that's what I already added it to my textbook.
Yeah.
Just recently as well. Medical leadership aspect of that, because,
Yeah, it is on there, and part of that is walking through, and again, to Paulo's question, like, how does some of this come up? Sometimes it's not as obvious as pulling out the laminated tool as during a quality of care review, when we're talking about, what would somebody else do? Like, okay, this, this nurse or this physician or this, you know what I mean? New versus veteran, new to the organization. Have they had training recently? Like all of those sorts of questions. And sometimes those nuances come out during that quality of care review, or pieces of that, right? Where you've got other experts that are on there that would say, well, everybody else, would be very familiar with this process or this policy or something. So, helping to answer some of those questions, but it's not necessarily pulling out this laminated tool and walking through every single question. Certainly, if there's any sort of question of individual practice, we would be using this tool.
I find it hard to believe that we could receive such consistent praise for how treat our patients without there being some version of this being applied,
Right. And I will say subjectively, leaders have really expressed appreciation for the tool because it takes a bit of pressure off of them. Like this is a tool that they can apply and land, and it takes away the subjectivity of I'm doing this to you and I'm following this process. And so I do see it pinned up on everyone's boards, including educators. We want to do more to track. I think the Global Workforce Survey will be a good one. And yes, the inclusion on the critical incident report is a way of us continuing to try to figure out how to best embed just culture.
So just a comment that might be a question as well, but I really enjoyed seeing that, appreciating that we can use multiple, but also just seeing the level of coaching across multiple final stages, because I think at the end of the day, there's always room for growth, right? And I think people accept that. But that leads me to the coaching on the leadership side. So how are we identifying, not to be negative and saying that leaders are trying to make the wrong decision or maybe not the most appropriate in that scenario, but what's our barometer for coaching at the leadership level based on executing the just culture?
Yeah, it's a good question. So we did a lunch and learn on this. It was an hour for all the leadership on the tool itself and applying it. We know we're not done. There's more to do.
I think the other side is that we've also engaged with human resources, right? So if a leader's, going down to human resources and saying, there was this incident and we need to work together and, I've got to discipline Sally and stuff. Part of it is actually educating the human resource department around this common language, right? So, that they should be sort of walking through this decision tree, like, help me understand where you got to, a discipline or something like that, right? Well, this is a repeated pattern. This is, and actually seeing where they land as well. So I think it's not just for leaders, it's also for, that checkpoint can become other departments, right? It can become human resources. It's our wellness staff as well. Because part of this is coaching and supporting and wellness and what we're offering to staff as well.
And I'll just add one thing is the next step that it's high level language at the bottom, intentionally so that it fits so many different scenarios you can put through the tool. But we are working on a tool to support leaders on what's next. So once I identify it's reckless behavior, who do I need to get involved? In what way are they involved? What action should I be taking? And we've gotten everyone to be informing on that. So at what levels are educators involved? Do they help manage reckless behavior? Are they only involved with human error? And then again, just trying to clarify roles and responsibilities and placing them in this shared language in these buckets.
Diane and Finn.
I just want to say, I think what this overcomes is, from my experience, of how healthcare was. It was very punitive. You were afraid to make a mistake. When you made a mistake, you got in trouble. You got disciplined. It was very adversarial. And to see the change I'm a big fan, have been for years. So it's a huge change to support our workers so that they're not working in a culture of fear. And hospitals have been traditionally a culture of fear if you make a mistake, especially at the bedside.
Right.
I remember the first time I made a med error and then what the head nurse told me to this day, and that's like 45 years ago. But that culture of how it was to how it is now, this is just wonderful. Thank you.
And there's a question on the Global Workforce Survey, right, that says something to the effect of, if I make a mistake, I will be disciplined, or something to that effect, right? And so I do think that that is a good barometer for us, particularly when you engage with human resources and you say, how many people have been disciplined for making a mistake? How many people have been fired for making a mistake? And they will tell you, like, it is so, so small. And yet, as we watch that question, I do think that that question will be a barometer for us around people feeling safe to bring things up.
Maybe I'll just first off to say, kudos to Kellen. I mean, amazing work, been, hip to hip and sort of, watching it grow. It's been such a pleasure. And I think where it has been successful is that having a champion, taking it from beginning to end, but all levels of the organization. And maybe that's my comment around the fact that we did it in concert with the medical leadership as well. Hugely a big fan, as you heard, because people want to use it at home. So I think that speaks to, how it resonated with everybody across the organization. And it brings together multiple facets of the organization, whether it's the leadership, whether it's frontline staff, the medical side, the administrative side. And then on top of that, I think we talked about this at MAC, is that it is not just the concept of the tree. It's about how you show up as a leader, how you show up thinking in a situation. So it could be a conversation between a leader and a leader. And instead of having that assumption surface first, you step back and ask the question. What was the situation? What could have been, what could have been done differently? How are we going to manage this? As opposed to making an assumption of blame. And so I think it's the ideal is to be in the fabric of how we lead. And so I think that's really important as this journey evolves. Obviously, it starts with that knowledge, having a framework. I can tell you, having spoken to other organizations, try this, it never gets off the ground, right? Because you need that upswell of everybody being on the same page, and that's all kudos to Kellen. So, congratulations.
Sorry. I'll love it.
One more comment. Sorry, I really do love this.
To thank Kellen.
Sorry. And I just thought, like, looking at this in today's environment, knowing, mental health and just knowing the systemic pressures on staff, I think, like, where we know this starts to really take wind is, like, I think we've seen that evolution based on Diane's comment. There will probably be a lot of people in the first bucket, probably many years ago, and we're probably evolving from there. And I think we'll probably evolve from where folks are disclosing more of their maybe hidden impairments or, their disabilities. And when there's that openness, I see us moving further to the right on this path, which I think could be an indicator of just culture is really hitting its stride and it's welcomed.
That's a great point.
Thanks.
All right. Thank you so much, Kellen. That
Thank you
was
for having me.
extremely informative. I think people could have asked you questions and made comments for hours, but then we would be here until midnight. So
Well, I'm always accessible via email if anyone has any follow-ups. Thank you so much for having me.
thanks. Have a good day.
Thank you.
There's no open matters for discussion. There's update, starts on page 111. And yeah, once, I did try to highlight in my note that we're in a challenging time right now. And so it's just really important that we keep being here to support management, and we know we have an incredible team, but it's not going to be easy right now. So thank you. And I'd also, on the next few pages, are just highlighted again, the number of times that people showed up. Many of us came to hear Patrick speak at the country club, and it was fabulous. I think there were 8 board members and many senior management there, and Patrick did a fabulous job. So, yeah. All right, Jane, I'm going to pass it over to you, but first want to thank you for attending because it was a big commitment. I know it was 2 afternoons.
Yes.
I'm sure you found it very rewarding, but it was a huge commitment. So thank you for taking the time. Okay,
well,
as
for-
much as you would like.
Okay, well, first of all, thank you for allowing me to attend. It was an interesting session. It was 2 half-day sessions, and I know there were no good staff that attended as well. I appreciated the opportunity because it helped me with my equity journey and learning. And it also helped me to understand the issues, the equity issues, because not having a workplace anymore, you tend to get a little out of step. Like I felt I was a bit disconnected from that. So it was a reminder of what some of the equity issues are that people are dealing with and the challenges that people are facing. There were some fabulous keynote speakers. I think my notes are pretty self-explanatory. I'd be happy to answer any questions if anybody has any, but again, I thank you for the opportunity. I didn't realize I had to do a PowerPoint, so that was, I think I would have taken different notes maybe, but it was, it's good. It all worked and I'll know for next time.
Apologies for
No,
that. So
it's because I'm new. I mean,
no, but we should have made sure you did know that. So
Okay,
it doesn't
no
have
worries.
to be a PowerPoint. It can also be verbal notes. Yeah, so,
No.
sorry.
oh, it can't anymore.
Be a PowerPoint.
Yeah.
I didn't even know.
My understanding,
I had no idea, Jane.
Thanks, Stephanie. My understanding is that this is now your process. and I just happen to be the first.
You do.
Well, no.
Way to go, Jane.
That's good.
I was supposed to be at work. So there you go.
I'm glad you mentioned you didn't know, because I think this is a learning opportunity for all of us right now. So, thank you. Any questions for Jane on the CCBI conference? Okay, well, thank you so much for taking the time. All right, Bill, I will pass it over to you. Page 121, Quality Committee Report.
First of all, I just want to extend my thanks to Diane. She chaired the April 15th Quality Committee meeting. I was absent, so appreciate that, Diane. And I'll kind of run through what was talked about, but certainly I'll ask Diane to interject if I missed something or something didn't ban on. So the program presentation for April was the emergency department. Of course, we've heard a lot about the emergency department, but maybe just some of the things I wanted to I thought were good for highlighting from the package, and I'm sure everybody's read it. Just really kind of looking at the emergency department, right? Department as it's the primary entry point, as we all know, for inpatient medicine and certain surgical and specialty services. Certainly that critical driver, as we see the NB flow, critical driver of the hospital-wide patient flow and access. And just some of the stats, certainly 39 individual rooms, certainly trauma and mental health, the negative pressure room, the ultrasound, the dedicated room for regional sexual assault, and the inmate partner violence team. And really kind of staggering, like when we think about like almost 48,000 visits in 25-26. And I think we've heard this before, certainly the 131 on average per day, which has been pretty consistent, and maybe it's a bit higher now. And then the 33 ambulances that come each day and almost 12,000 through the year. So, and just kind of the big breakdown of 85% adults, 15% pediatrics. And then just really just sort of looking at some of the stats of the CATS 1 is 27%, CATS, sorry, 1 to 2 is 27%, 3 is 53%, and then 4 and 5 at the 21%. And then remember physicians, 17, and then 77 RNs and 20 RPNs. One of the things that was really kind of striking is a couple of the stories. So certainly the staff story. So we probably would have heard in the news, certainly a very tragic event where a child was in an accident transported here to ED, and unfortunately the child had succumbed to her injuries. So how the family had identified that they Indigenous background, and then really how the support of the DEI lead, Joy, and certainly the care team worked certainly so respectfully to facilitate the family's request for this smudging ceremony. And then really also too, like the first responders and everybody that dealt with that case, just the challenges and the support they were provided, right, through the DEI lead and also the hot debrief alignment, through the hospital's process. So it really just speaks to how we support, the patients, the family, and also our staff through such a difficult situation. The patient story was certainly, if you read that, certainly about the 36-year-old patient that presented at ED with chest pains. Certainly no history of health or heart concerns, and certainly fit, but was certainly quickly, rapidly triaged despite the high volumes when he came in. And just really the patient's feedback and how he highlighted, the reassurance he was given, the professionalism and the calm that was provided by the nursing staff, including the interdisciplinary transfer, because he had to go to St. Mary's to the cath lab, and really just crediting ED for saving his life. I mean, somebody that was certainly healthy, and even just his humility that he thought that he was, he came in unnecessarily, like that he was taking up resources, but certainly such a, so how important that it was that he did come in. So certainly that spoke to how he was treated. The other report that we had was the annual review of the ED return visit, that quality program, so the once a year. So really that's focusing on identifying and auditing the understanding of the cause of patient return within the 72 hours. So last year's priorities were the senior-friendly initiatives, improved pediatric access, and enhanced communication. And some of the key achievements, of course, as we've heard, the launch of the Pediatric Rapid Assessment Clinic. Some of the key improvements have been the avoiding discharge and critical diagnosis tests remains pending, ensuring repeat and normalized vital signs before discharge, and certainly improvement of the management of follow-up for frequent ED users, and reducing the return visit link to patient leaving without being seen, and then certainly strengthen that communication and documentation when patients decline admission. And the other program update we received was the clinical service growth plan update. So again, that's the area where it's aligned with our Elevate Partnership and Care strategic pillar. So some of the highlights were under Elevating Specialized Care, just the achievements that have been recognized, advancing specialty services such as the Regional Breast Reconstruction Program, the enhancement of the Regional Liver Health Clinic, and the new Rapid Assessment Clinic to reduce ED pressures, the first trimester clinic, and the integrated newborn care model, and the strengthened oncology clinical trials. Under collaborating more with community care, like it's the Ontario Health Team, the Primary Care Network, to improve it, as we've heard, the navigation and coordination for high utilization patients, the level 3 ICU capabilities, and certainly the diagnostic imaging pathways and the regional leadership in choosing wisely. For innovating care work that's underway, certainly the AI-driven predictive analytics and our clinical decision support and the robotic automation use. And finally, the access to care, so that external ED review that we've heard about, and those recommendations, and also too, we've heard about the expedited endoscopy program, and then with strength and certainly with strength with surgical models. So those are just sort of the three areas, and we did certainly review the quality monitoring scorecard, and we had our MAC updates. So that's kind of what April was. And I missed anything, Diane? So again, lots of good questions from members, and certainly an engaged group, and certainly very positive feedback in the feedback of the meeting in general. Just again, always high quality reports and great questions from the members. So.
Thanks, Bill. What questions do people have for Bill? Oh my God. Recognizing that we will speak to organizational flow, so we won't touch on that.
No. Realizing that you're going to have to call a friend. When a life ends, what does that look like? Like, is there an acknowledgement for the staff? Like, is there a moment of reflection of a life? Like, what does that look like? But, like, what does the team that serviced that patient do at that moment? Like, what does that look like?
And did you talk about maybe there's sort of a debrief, right? I think with all everybody that's involved, right? I think right from EMS to Water Regional Police and all staff, right? So there's certainly that debrief, and that's, I think, fairly fairly quickly right after the event.
I'm not really asking that, I'm just,
Sure.
what I'm asking is there an acknowledgement of just like a moment of reflection of a life has come to an end? And it just, before everybody gets into the clinical side of it, like, is there a moment to acknowledge that? Like, what does that look, does that happen?
Like, can I just tell you, from a clinical point of view, you don't have time.
You don't have time? Okay.
You, and when you're resuscitating someone, your focus is on saving life.
Yeah.
And being as technically skilled as you can be, knowing that you might not succeed.
Right.
I don't know, Jenny might wanna, and Margaret might wanna weigh in as well. And when you don't succeed, it is difficult because, but then your next priority switches from that patient to their family and loved ones.
Mm.
Then you switch to the comforting and the supporting, and pastoral care will come in,
Yeah.
social work is there in the emergency department, whatever. So once you've done that and you've cared for your patient and their family, then you get your opportunity for your reflection and your debrief and your support, but you do carry it home. There's just no way you will, but you learn to adapt and you learn to rely on each other. You will talk through later. Like, I know Stephanie was at that one because she and I talked about it. And she said there was a police officer there who, obviously young police officer, who will be traumatized forever from this. And so she recognized that as a senior admin going to this terrible catastrophic event. And so made sure that that police officer was part of everything. So it takes a village to sort it out, but there is no, because that's, it's very subjective based on your religious and your values. It's not generally something I would say that's happened in my experience.
Okay, just wanted to understand.
Winnie, Jenny, did you want to add anything?
Jenny.
Jenny? Oh, you're on mute, Jenny. Yeah, she's off mute, but
She was off.
no.
Her mic.
Yeah, I think there must be a problem with your mic. Oh, there we go.
Okay. Sorry.
Oh, sorry, Jenny, did you want to add anything
I-
to?
If it will work, I'm not sure I have
Yeah,
audio.
we can
Oh.
hear you now. Thank
Oh,
you.
perfect. Okay. I just wanted to comment that our spiritual care program is fantastic. Acknowledging what Diane said is that, I mean, we are moving from one activity to another, and our presence is needed immediately in all of these situations. But our spiritual care team cycles back. Sometimes they will come on the next shift where the same staff are working, and they just very, very quietly, very, very graciously check in, and they will go from staff person to staff person and just, how are you? I heard the last shift was terrible, or it was difficult, or it was challenging. And so they've created space in the way that they do their work to acknowledge that we all experience it differently. Some of us may not be ready to talk about it on that first day, but they do create that space to keep it open for staff who want to talk about it.
Thanks, Jenny. Margaret, did you, I don't want to put you on the spot, Margaret, but I just wanted to know if there was anything you wanted to add.
Yeah, I went to St. Joseph's Health System Mission Day today. And it was really interesting. We talked a lot about leadership in healthcare and also about the mental health burden on leaders and also on frontline staff. And I think one of the key messages that I heard today was around authenticity. So, as healthcare providers or someone in a position within a hospital, you do have an emotional response to these events. And stoicism was really taught for a long time in many institutional settings. But I think providing that space to open up and express real emotion and have support around that is so important. So it was a really incredible day. Like, it really made me think about what we could be doing here around some of just things that we can all learn, sharing together. There's also a speaker from the University of Michigan talking about sacred moments in healthcare, so moments that are really profound and transformative for the healthcare team, and leading rounds within hospitals now where people have the opportunity to talk about that. And those can be both positive or difficult situations, but sharing and opening up the space for that. And, spirituality is not just religious belief. There's also, chaplains provide other forms of support as well. They're often the folks who provide mental health supports in so many of these settings, and they're trusted because they often have, there's a sense that they can hold the information confidential. I think that's really important as well for people to have an outlet where they know this is a safe, trusted source who's not going to share the information that you're sharing with them with anybody else. So just a couple of comments.
No, that's really great, Margaret. And yeah, Diane, Jenny, Margaret, thank you so much for adding that in. I think it was really important for us to hear, and thanks for asking the question. Other questions for Bill? Okay, we will move on to the Resources Committee, page 126 and follow.
Thank you, Lynn. And so the briefing note's been shared with you in the package, and I'll just provide a quick and summarized update. But before I get into some of the items shared, we did have a brief change or a change this just before the meeting. As through ministry notification, it was notified that we will actually be seeing a $2 million reduction in PCOP revenue this year, or sorry, for the 25-26 year. And in addition to 300,000 in additional costs from reconciliation and invoices due to this. That will actually land us at a year end. It changes our year end from a 9.6 million to $7.3 million favorable. But I did want to ensure that everyone understands that that actually would put us, given the 8.8 million in PCOP reconciliation from previous years, in this year's, it would actually put us at a deficit of 1.5 million, not including that 8.8 million. In addition to that, and the work that the finance team has put in discussions with MOH, they have confirmed that full PCOP in 26-27 will be honored and will be reconciled in 26-27. And then I know that's a heavy update, but just to conclude some of the other items within the package, most of our where we saw some positives in revenue again came from our PCOP funding, quality-based our QBPs, and some other revenue positives. We do continue to see expense pressures in salaries and wages, employee benefits, overtime, along with supplies and drug costs. Our balance sheet strength, we do have continue to have a strong cash position as of March 31st, with at HSAA target range of 1.43, which is still strong. And I think the key items, in addition to the updates that came before us here today, although financial performance was strong, cost pressures continue and are increasing, and performance continues to be a sensitive operational capacity and for workforce availability. So with that, I'll pause there and take any questions or phone a friend.
Thank you, Paul. Before I open it up for questions, I'm going to ask Trevor to speak to, I know at the Resources Committee, there were a number of one-time adjustments that happened in 25-26, which I think it's important to be aware of because they make that, the loss of 1.5 million is not good. But the loan that we wrote off from CMH. So if you could just go through the one-time items, because I think it helps us put this in a bit better perspective.
Yeah, it is a very good point, Lynn, that you make there, that we made a number of decisions this year to clean up our balance sheet to make sure it is as strong as possible as we move into 26-27. That included forgiving a loan from the CMH VA of just under $500,000. We shifted our inventory program, just-in-time program, to HMMS. We previously had inventory products in the units. Most hospitals will expense it when it hits the units, so we drew that down, which caused us to adjust our P&L between $400,000 and $500,000. We had a significant year-end labor accrual for potential settlements that we talked to of about $700,000. So there were a number of aspects that we went through to make sure that we were trying.
There was also, I believe, because the labor accrual, I don't necessarily consider a one-time thing because but there was also the accounts receivable. We changed the accounts receivable and that was 400,000 or something. I
Right,
think.
so we adjusted our bad debts. We looked at our bad debts critically in that area. And I could say that there's some of these that involve judgment. And as we went into third and fourth quarter, knowing that we were going to be picking up PCOP funding, we made some investments in our facilities and some IT equipment that we could move ahead into 25, 26 to position us as well as we could going into the upcoming year, which is a pivot year, right? As we shift into harder economic times and we'll start to experience that, just a bit more on the backdrop on the PCOP conversation. We've been seeking confirmation from the ministry for a period of time on our maximum eligible PCOP funding for 25, 26. It came in late yesterday. It's like, of course, they're working on their stuff. And I thought it was important enough to provide Paula with an update in advance of the May meeting, just so that we're not talking about that shift at the May meeting with the auditors. And ultimately, in simplicity, just to frame it, our envelope for PCOP is 23.7 million. The ministry approved 21.7 million in our funding workbook this year. We believe that if we exceeded the 21.7, that they would have funded us to the 23.7 million level, to the max. And that's not without precedent. There are other hospitals who have gone through this where they've received what they call accelerated PCOP funding. And based on communication we had with the ministry, we believe that we would have been able to do the same, that we would be able to shut the year down. I think that we're looking at different economic times, the government looking at things differently, and they're saying, no, we approved 21.7 million this year. Those extra volumes are unfunded. We will give you the full funding allocation 26, 27 and reconcile that piece. So, it brings us into still a healthy surplus. Ultimately, I look at 7.3 in the environment we're in, where lots of hospitals are reporting deficits. But I would say that this is a message into our organization that we're sending consistently. 26, 27 is going to be different. I'm looking forward to our June meeting, where we look at May financial results and how we're doing, because that will talk to how effective our budget process was. And we're going to have to be on top of that. That's why we've engaged Ernst & Young on a financial and operational sustainability review, just to help position ourselves, to help us think differently about how we manage our finances and in the world that we're moving into. That helps.
So we have 100% confirmation that the 23.7 is baked into 26, 27, which is fabulous. And I just want to say, I am really glad that you brought it forward, even though you only found out yesterday and didn't have time to give us a heads up. I appreciate it coming. The sooner we know, it's that I think that's better, and it's just good for us to all understand exactly what it's saying.
Thank you. I guess so. I need to just flag it. Let's just talk it.
No, I appreciate it. So, what questions do people have for Paulo or Trevor? Miles and then Monica.
To what extent is it possible that some of the overtime and wage-related expenses are enabling us to earn this extra PCOP money? Is there any kind of a relationship?
The overtime allows us to operate more beds, which generate weighted cases. You could argue that the overtime and the volumes that we're experiencing has allowed us to shoot way past our weighted case target. So there is a complementary factor there. It's not a great way to operate. We shouldn't be running unfunded beds in the world, but that's the message back to government. We'll do what you fund us for, and we're going to have to really watch how many unfunded beds are.
To some extent, you don't earn extra revenue without incurring extra costs.
Our volumes were high. Like, there was a day where we were struggling to hit our PCOP targets. This is the first year we've exceeded, actually, and as I talked to the finance team. So we've done a good job at coding. So the work that Kyle and his team have done is really important, that we really, and in partnership with the physician group, honestly, they really work carefully to maximize our weighted cases in that respect. We've done a lot of volumes through incremental surgical recovery. We've really worked hard to meet community need. I think it's reflected in our numbers.
Monica.
Trevor, I'm just wondering if you could just help us understand the impact to, your cash flow, like your working capital. Is money going out or less money coming in? Or does that only change your your free cash?
This change will reduce our unrestricted working capital by 2 million. We still enter the year in a good position. We've got approval up to 20 million for the HIS loan, which I expect will be enough. It's a big enough number in my mind. If we can keep our costs in control and run a balanced budget, we should be in good shape relative to many other hospitals in Ontario.
So on page 129, instead of 14.8, we'd be at 12.5 then.
Yeah.
It's a pretty good spot. Not that I talk about going into debt lightly. I tend to be a debt averse person, so I'll have to get used to that reality. I'd hit 26, 27.
I'm going to read a question from Sarah. Sarah's in Europe right now with dodgy. Oh, and then I do see your hand next. Thanks, Margaret. I'm just going to read Sarah's question first. So Sarah, do you expect much more improvement in coding once HIS is in place?
There'll be a learning period, so we might see a dip initially. We're gonna have to really focus on that in Q4 to make sure we don't see a drop as we shift to the new system. But I would say that our coding practices are pretty strong, so I'd say comparable. I wouldn't say that it's gonna see better because we're already doing what we can with tools.
Thank you. Margaret. Oh, and Sarah gave you a thumbs up, so.
It's really a comment. I still find the financial performance of this hospital so remarkable. To stay in the black in the current situation, I just think it's really to be commended. And I think we're very grateful for your leadership, Trevor, around this. It's incredible. Like, really.
Thank you.
Thank you, Margaret.
Yeah.
What other question? Oh, sorry, Margaret. Did you have a follow-on?
No, thank you.
Thank you. What other questions do people have for Trevor or Paul? May I have someone put forth the motion to receive the preliminary unaudited financial statements as presented by management and upon recommendation of the Resources Committee at the meeting of April 27, 2026, recognizing that the net surplus is 2.3 million lower than what you had in your. Someone could put forth the motion, please. Monica, thank you. Seconder Bill. Any additional questions or comments? Anyone opposed? Carried. Thanks, Paul. Thanks, Trevor. All right, so PFAC update. Nicole came and spoke to us about patient and visitor parking. And really, the whole story was about the new supervisor, Matt, who is very actively changing a lot of things. He's actively managing the parking list, the lots, the vendors, repainting the lots, doing physical site and signage assessments. So just, yeah, very positive changes to parking. We had an AI presentation from Wakas, which we have to have part two, because there was so much for people to absorb. It was decided that he did the first part last night and he'll come back and people have more questions. And then Joy and Diana spoke to us about the inclusive communication guide that they're developing right now. And there was a lot of feedback and engagement, I think, PFAC on that. So anything you want to add, Leanne?
Well, it was a night of presentations.
It was a night of presentations, but it was good. It was really interesting. And there's always at PFAC a lot of engagement from everyone. So it was a really good night. Any questions for me on that? All right. Okay. So there are no CEO update in the open. The events coming up: Grand Rounds on May 28th, the Golf Classic on June 1st, and Sarah's Walk on June 14th. Just a reminder, there are 3 different distances: 22, 11, and 2. So you can just walk 2 kilometers and come have lunch with us at Stillwaters if you want to join in. It's lots of fun. And the next meeting is Wednesday, June 3rd. And may I have a motion to terminate, please? Paula, thank you. All right, we will regroup at 6:30.